Talking about healthcare associated infections. What are hospital associated infections or the healthcare associated infections, or generally we call them as nosocomial infections also. So to define it, the infections which are acquired in the hospital by a patient admitted for a reason other than the infection in context, or in a layman language, if at all we can say, if a person has come with an X disease, but during the hospital timing, during the hospital duration, he or she has developed a Y disease, is nothing but the hospital acquired infection or the healthcare associated infection. An infection acquired in the medical setting in the course of medical treatment is nothing but the healthcare associated infections. Talking about the history of hospital infection control, it is as old as mankind, and of course, since mid of 19th century, the existence of infection control practices we have been talking about. The pioneers who have worked for infection control and about the aseptic precautions: Semmelweis, Louis Pasteur, Joseph Lister, the father of antisepsis, Robert Koch, Florence Nightingale, and number of people have worked for the development of infection control practices and adhering to the infection control practices. In its broadest sense, infection control includes all the policies and procedures which are designed to minimize the occurrence of infection in a given setup. Talking about the infection control program is basically comprising, it operates at two levels. One is the executive body and the other one is the advisory body. So first and foremost, talking about the advisory body, which comprises of the whole hospital, that is the Hospital Infection Control Committee, which adopts the legislative roles and policies. I would request all of you to fill up the attendance sheets, and questions can be put up in the chat box. After the completion of the presentation, it will be taken up one by one. Right? So talking about the advisory body, it is the Hospital Infection Control Committee, which plays the legislative role. And there is an executive body which works on day-to-day basis, which is formed by the infection control team. So talking about infection control program, infection control ICP, this program is comprising of the HICC, the Hospital Infection Control Committee. Then we have the infection control team, which is the ICT. And third one, what are the policies and procedures, what we need to follow in our day-to-day practices, that has been formulated in the form of SOPs. And these SOPs have been formulated in a complete manual, which is named as the Infection Control Manual. In many places, we formulate it, we write the SOPs, but definitely somewhere on the shelves of our infection control rooms, it is lying down. It's not just the purpose to store and save it out there. We have to follow it on day-to-day basis. So what comprises of the Hospital Infection Control Committee? To talk about HICC, the main persons, the executive members are as such, the hospital administrator or the chairperson, who can be the director of your institution or the medical superintendent or the principal or the dean of your institution. That is the main person who will be building up the administrative roles and responsibilities of every person who are there in the HICC. And most importantly, for the financial crunches, for the administrative matters, whom do you actually look upon to? So some administrative higher up position has to be there, who includes as the chairperson of the HICC committee. Then the second most important member of the HICC is the member secretary. The member secretary of HICC is generally a microbiologist who helps and who formulates what are the different infection control practices and policies which needs to be followed and adhered to the whole system of the hospital. Thirdly, we have the clinical microbiologist, or it works as infection control officer. This also somebody from the infectious diseases or from a microbiology side can be the one who can play as a role of infection control officer. Fourthly, the most important person, the infection control nurse. It is said that on a bed, 1:250, on 250 beds, one infection control nurse has to be there. So without the infection control nurse, which comprises of the infection control team who works on daily basis, will go and carry out the data, carry out the other practices, whether they are being adhered or not, it has to be looked upon by the infection control nurse. Then we have the general physician, general surgeon, director of nursing, who helps us with all the nursing probabilities, the infections, where all it is prevalent, wherever the hotspots are there. So the nursing officer or the nursing superintendent plays a vital role in formulating the hospital infection control committee. Then we have the occupational health physician or the ID specialist. If all the particular hospitals, like the tertiary care hospitals, maximum times they have ID specialists with them. So they also play a pivotal role in HICC committee. Other representatives from all the clinical branches of your hospital and other department representatives like somebody from operations who is helping out in the GDA and the support staff, pharmacy, whether the drugs are being adhered to the strict protocol policies or not, CSSD, whether we have the central sterile supply department, then the maintenance and the housekeeping team for maintaining and cleaning and disinfecting the areas of the hospital. So in short, we talk about the Hospital Infection Control Committee has 7 to 8 prime members without whom this HICC committee cannot be formulated. The chairperson or the administrator who takes up the responsibility of the financial and the administrative matters. Member secretary and the infection control officers being from the microbiology department will be very, very important as they will help in adhering the policies and the procedures of the hospital. Infection control nurse formulates the high end and the exclusive part of the infection control team. Then people from general physicians, general surgeons, nursing superintendents, ID specialists, and departments of operations, pharmacy, and CSSD maintenance group. They will help us in providing the better healthcare facilities. Moving on, next we have the infection control team. From that time, I'm just saying the day-to-day practices, the day-to-day challenges are reported to the ICT, which comprises of the infection control officer, which has to be a microbiologist, and infection control nurse, which on every 250 bed, we have one single nurse, infection control nurse. So infection control team members are responsible for the day-to-day functions of the infection control. The third component of the infection control program is the infection control manual. That is the prerequisites of this infection control manual is first and the foremost being the organogram of the hospital, what we have just spoken of in the infection control committee, hospital infection control committee, HICC. So the organogram has to be followed. Who is the administrator, who is the chairperson, who is the member secretary, who is the infection control officer, who is the infection control nurse. And based on that, the different other members of the HICC will help you adhere to the policies. Then the risk categorization of the different hospital areas, which are the hotspots, which are at high risk areas. Then surveillance mapping of risk areas, which will be dealing in the next, coming presentation. The surveillance part of all the 4 parameters of all the healthcare associated infections. Then hand hygiene being the important and the representative aspect of cleaning and for healthy healthcare environment. Then the standard precautions and the isolation precautions. As we all know, we have been talking during this COVID era, this pandemic, 3 years are over now. Still COVID is prevalent with us. So what are the basic standard precautions, what we need to take up? What are the isolation precautions? We all have, I think, gone through 3 difficult years of COVID in this pandemic. What are the high risk areas? What are the hotspots? What are the occupational exposure to blood and body fluids? Any NSI, any needle stick injury, any body fluid spill is there. So how do you take care of that? What are the recommendations of the different cleaning and disinfection areas at ICUs, at cath labs, at operation theaters, dialysis units, your critical and the non-critical areas? What are the different recommendations? It should be also jotted up in your infection control manual, and it should be referred as and when required. Then one more important point, which is the vaccination policy, what your hospital is adhering and what are the facilities, what you're giving to your employees. I hope the screen is still visible to everybody.
Yes, ma'am.
Yeah, fair enough. And then after this vaccination policy, it is the outbreak management. And I think the world has spoken about the COVID pandemic, how everybody, all the hospitals has managed this outbreak. And lastly, about the mortuary points, how do you keep it? What are the chemical disinfectants? What are the infection control practices we are maintaining in the mortuary? Nowadays, with the NABH 5th standard, mortuaries is also taken care of. And in a setup like mine, I have a medical college. So they look forward what are the infection control policies in your mortuaries also. So as I said that, the organogram of the hospital, risk categorization, surveillance mapping of risk areas, hand hygiene, standard precautions, isolation precautions, high risk areas, occupational exposure to blood and body fluids, recommendations of cleaning and disinfection of the hospital areas, especially the ICUs, cath labs, OTs, dialysis, and the critical and non-critical areas. Then we have the vaccination policy, outbreak management, and the mortuary infection control practices. This all comprises of your infection control manual. So as I said that, we have the HICC program, we have the ICT, that is infection control team, and thirdly, we have the infection control manual, in which all the policies and procedures of all these 10 points have to be jotted down. Now, talking about the functions of HICC, it mainly caters the HAI surveillance, that is the healthcare associated infection surveillance. Mainly the HAIs are catheter associated UTIs, central line associated bloodstream infections, ventilator associated pneumonias, and surgical site infections. So how does it work? So basically, they have to identify, you have to report what are the cases, finally analyzing the data and the prevention of HAIs. So how does a surveillance system works? The identification, the reporting of the surveillance, then how you are analyzing the data, whether this X or Y parameter comes under the surveillance parameter, or it is definitely a COTI or a CLEPSI, how do you check it? And finally, how do you prevent wherever the hotspots of healthcare associated infections is prevalent? Then thirdly, the functions of HICC, as I said, making up a manual, how the proper policies are jotted down. So making policies of proper antibiotic usage, eventually helping us to develop a good antimicrobial stewardship program. So when you're making a policy, finally, the implementation of antimicrobial stewardship program is quite also helpful for, which is one of the functions catered by the HICC. And lastly, of course, as we all know, infection control played a very important role when there was an outbreak, when there was a pandemic. Hand hygiene, isolation practices, your standard precautions were all a keynote to get away from this COVID. As I've already defined, what is the definition of surveillance? It is nothing but a systemic method, how you're collecting, how you're consolidating, and finally analyzing the data so that the prevention of the healthcare associated infections can be taken. So the cycle, it rotates it in this way. Implementation of surveillance, their goals are defined, surveillance protocol and data collection, how do you collect it, the different parameters, different checklists, different surveillance data are there. After you have collected the feedback, how you are analyzing, how your interpretation of the data, what is the comparison between when you're giving it as an HAI, when you're not giving it as an HAI. Thirdly, what is the prevention? What are the CAPA actions? What is the corrective and the preventive actions taken for the prevention of this healthcare associated infections? And finally, last but not the least, how do you evaluate? Once you have interpreted, when you have consolidated, once you have already taken care of the interpretation, then prevention is done. How much is the reduction of your healthcare associated infections? It is being seen in your hospital setup. Let's say in a year earlier, you used to have 3 to 5 needle stick injuries or 3 to 5 ventilator associated pneumonia cases per month. But eventually, with your adhering to the practices, proper practices, taking up the standard precautions, how much you could prevent, how much you could decrease the data of your institute, of your hospital in the prevention of healthcare associated infections, right? Talking about catheter associated, the first and the foremost healthcare associated infection, catheter associated urinary tract infection. To define catheter associated, a UTI where an indwelling urinary catheter was placed for more than 2 calendar days on the date of event with the day of the device placement at day 1. So a UTI which has been carried up with the indwelling catheter for more than 48 hours is considered to be a catheter associated urinary tract infection. इसके भी further 2 types are there. One is asymptomatic, other one is symptomatic urinary tract infections. So when we talk about SUTI, symptomatic urinary tract infection, it has to meet one of the following criteria. That is, indwelling urinary catheter should be there for more than 48 hours with the day of device placement as day 1. And apart from that, at least one of the following signs and symptoms has to be present, which is fever has to be there, suprapubic tenderness, costovertebral angle tenderness, or urine culture positive for a particular or maybe more than one organism. So these are the prerequisites when you're labeling a patient for symptomatic urinary tract infection. Moving on to asymptomatic bacteremic urinary tract infection. This is with the presence or without the presence of indwelling urinary catheter. And generally, patient generally don't have, as the word itself is describing, it is asymptomatic urinary tract infection. So there are no signs and symptoms, no fever, no urgency, no frequency or suprapubic tenderness is there. But there has to be routinely, if a person is going for urinary urine sample, a significant bacterial count, that is 10 to the power of 5 colony forming unit, with one or more than 2 species of microorganisms can be isolated. So catheter-associated urinary tract infection includes systemic urinary tract infections and asystemic bacterial urinary tract infection. So according to CDC, 0 to 5.3% in critical care units and 0 to 3.1% in inpatient wards, the rate for catheter-associated UTIs we have seen. And overall, when we talk about the catheter-associated urinary tract infection, the most commonest organism is E. coli, mainly comprising of the Enterobacteriaceae family. E. coli, Proteus, Klebsiella, and sometimes gram-positive bacteria like Enterococcus and Staph, coagulase-negative Staphylococcus are very much prone for it. Somebody is raising the hand, I hope. If I can ask, somebody has actually. If you have a queries, please put it up in the chat box. That will be easier for us to deal it at the later part. So we have Enterobacteriaceae family main causative agents for causing catheter-associated UTIs. Then we have Staphylococcus aureus, Staph epidermis, coagulase-negative Staphylococcus is very much prone for causing COTIs. Then Enterococci and Pseudomonas also presents for more than 20% of catheter-associated UTIs. Talking about the surveillance part, how do you collect the data? So basically, the infection control nurse is the only one who takes up this data. How do you calculate the catheter-associated UTI rate? COTI rate is defined as the number of urinary catheter-associated cases in a month. The denominator is number of urinary catheter days in that particular month multiplied by 1000. And COTI rate in India has been considered from 1.63 to 2.1 per 1000 catheter days. This is as per the Indian data. Whereas NHSN data, CDC data are a bit different from that. Talking about Indian scenario, 1.63 to 2.1 is the documented data we have. So how do you prevent? So we have two strategies. One is the core strategy and the supplemental strategies. So what are basically the core strategies? As we know, what are the risk factors for catheter-associated UTIs? It is mainly based on device-related, patient-related, and caregiver-related. So when we talk about the device related, it has to be the type of catheter and what is the material used for the catheter. Generally, latex material is used for this catheters only, which is again a very high risk for causing catheter-associated UTIs. When it is patient-related, mainly females are prone for COTI, more than 50 years of age, diabetes, immunocompromised patients. And incomplete emptying of bladder has been found a very predominant and challenging part in cases of COTI. And caregiver-related problems are basically the aseptic precautions, if at all it is not being adhered, and if there is any case of emergency catheter, urine catheter, which has been placed up in the emergency room. So when we talk about these risk factors, the core strategies has to be how well the catheter is being inserted. In high risk of COTI and mortality races, such as women and elderly and immunocompromised patients, how well we are treating the patients, how well we are minimizing, how best we are taking the aseptic precautions so that the infections can be as less as possible. As there is a COTI insertion checklist, this is used in my institution. And these are the prerequisites, what we generally follow. What is the name, the signature, who has inserted the catheter, what was the date and time, who has actually observed it. This is also very important. Generally, the infection control nurse has to be one of the observers who will take care that how the catheter has been placed and who has placed, whether he or she has taken up the necessary precautions or not. And these are the patient label. What is the name? What is the ID? What is date of admission, bed number, location where the patient is placed. So when we talk about the checklist, there has to be some prerequisites, some post-requisites. So before the procedure, whether the appropriate actions were taken up. So this checklist has to be filled up every time. Yes, whatever it was adhered. And who will check the checklist? Somebody who has been the observer can do that. During the procedure, again, this checklist has to be followed up. And after the procedure, so pre-analytical, analytical, and post-analytical, how we talk in NABL, in NABH. So these areas are very, very important to be demarcated, and this checklist has to be filled up either by the observer or somebody standing next to the person who is inserting the catheter. So what has been the reasons? What are the indications why this patient was catheterized? So proper indications and proper reasoning of the patient has to be given. So talking about for how long we need to leave the catheters then and there. Post-operatively, within 24 hours, we can remove and there is no unnecessary requirement of keeping the catheter in situ. So more the time, the more the colonization of the bacteria and the other microorganisms can be prevalent. And please ensure that only the trained staff, they are inserting and maintaining the cleaning and hygiene of the catheter who is doing it. And insert catheter using aseptic technique. What are the aseptic technique? The primary being hand hygiene before and after insertion. Use sterile gloves, proper drapes and sponges, antiseptic or sterile solutions for periurethral cleanings, and single-use packet of lubricant jelly should be considered for. And properly secure the catheter. It has to be adhered well. Is there any problem?
Yes. Can you just show the previous image, please?
This is the one you want?
Yes, that's the one. Yes, exactly. Can I take the screenshot?
So the PPTs will be shared with you after this presentation. It will be sent to your links from where you actually enrolled.
Okay, thank you. Thank you.
We'll do the needful, sir. Okay. Okay. Talking about the daily surveillance parameters, these are the infection control, and this has to be a standardized one. This is for the catheter-associated urinary tract infections, for insertion of urinary catheters, for insertion of central lines, for insertion of endotracheal intubation. We follow this infection control daily surveillance. Like we have it for 1 to 30 days. We generally maintain it. So number of patients. This is a monthly data what we are collecting. Number of patients in a particular area. How many were urinary catheterized? How many were centrally catheterized? How many were ventilated? How many patients are having TB, active TB, MRSA cases there, if there is any VRE cases there, whether the nursing station was clean or not. They are all the parameters for the surveillance. Unit was clean or not. What was the BMW? How many times the BMW shift was coming? IV sets and cannulas, they were whether properly labeled or not. Pad pans and urinals were properly clean or not. Hand rub was, it was not a challenge, and I hope everybody was following it. And cleaning is done as per the protocol, that is for the GDA staff, and bedside cleaning and for oxygen and suction cleaning is done. And there is no expiry item from the CSSD. It has been labeled from any of the areas, which is either ICU or any critical or non-critical areas, any operation theaters. All these places have this infection control department daily surveillance chart. Talking about the brief, how do you catch up catheter-associated urinary tract infection event form? If any patient has been labeled as COTI, so what are the prerequisites? What are the how the form is to be filled? So completely with the demarcation of patient's ID, the date and the date of event, when the patient was admitted, what is the date of event? Like, is it exactly up to 48 hours when you are labeling it? For how many days it was kept? It was more than 2 days. उसके बाद insertion कब हुआ है, कब इसको remove किया गया? What were the signs and symptoms, and what was the laboratory finding of which particular bacteria has been labeled as catheter-associated urinary tract infection? So this was all about catheter-associated UTI. Very quickly, I move on to ventilator-associated pneumonias. So this is how your normal chest looks like, and this is how a VAP patient looks like. So when do we define VAP? It is defined as a pneumonia which occurs beyond 2 days or beyond 48 hours or there or after following endotracheal intubation, which is characterized by presence of new or progressive pulmonary infiltrates on the X-ray. The picture I showed just previously to this. Any signs of systemic infection, that includes any TLC count increase, any fever is there, any altered sensorium, changes in the sputum characteristic, or any ET secretion changes. And if there are changes, it has been sent to the microbiology department. So what is the causative agent which has been detected from the ET tube, from the sputum, or from the bronchial washings? So, and this is the second most commonest commonest reason of healthcare associated infections, especially in the ICU areas. This is mechanically ventilated patients leading up to ventilator associated pneumonias. So very quickly, if I talk about what are the different bacteria which causes early VAP is within 48 hours. That is Klebsiella pneumoniae, antibiotic sensitive gram-negative bacilli like E. coli and Enterobacter. MSSs, methicillin sensitive Staph aureus is very common for early onset VAP. Strep pneumonia and Haemophilus influenza are also common as bacteria involving early onset VAP. Culprits for the late VAP are, they are basically late VAP beyond 48 hours, and definitely they are mainly multi-drug resistant bacteria. We have multi-drug resistant Klebsiella pneumoniae also, which is further being treated up very well nowadays with the higher Aviobacterium combinations. Then we have methicillin resistant Staph aureus, Acinetobacter, Pseudomonas aeruginosa, and also ESBL producer. Also, fungal and viral causes also have the reasons for low and high incidence, moderate incidence for causing VAP. So how do you diagnose? We have this one thing called as, I think very quickly, if at all I can talk about, we have mechanical ventilation, then we have the baseline period, we have this VAC ventilator associated condition, then we have the infected related ventilator associated complication, and lastly, we have the possible VAP. So when do we call it as possible VAP? First and foremost, the CPI score, the 6 parameters which are readily very important. We give the scoring from 0 to 2. Temperature, whether it is normal, whether it is moderate, whether it is high. Then the TLC count, it is normal, less than normal, or with the presence more than normal, or with the presence of 500 band cells. This is how we score 1, 2. Then the tracheal secretions, whether we have any tracheal secretions, none, mild or highly purulent tracheal secretions are there. What are the radiographic X-ray chest findings? Whether they are infiltrates, there is diffuse or patchy infiltrates, or the localized infiltrates. And lastly, we have the culture results for the endotracheal aspirates, no or mild growth, moderate or florid growth, and the presence of the pathogen with presence of pathogen even on the gram staining. And lastly, the oxygenation status, that is the FiO2 value, more than 250, it is definitely ARDS, or less than that, it is developing or the absence of ARDS. So CPI score, it accounts clinical, physiological, microbiological, and radiographic evidence, all the 6 parameters, as I said, that to allow the numerical value, if we are completely adding it up, the presence of ventilator possible as ventilator associated pneumonia. And scores between 0 to 12, it is generally considered, and more than 6 is a good correlation for ventilator associated pneumonias. Also, when we talk about the culture, this part, when we talk about the endotracheal aspirates, the positive quantitation of the semi-quantitative culture methods are, we have 3 criteria. One is criteria 1 for ET aspirates, that is more than 10 to the power of 5 colony forming unit. For bowel fluids, more than 10 to the power of 4 colony forming units. For lung tissue and for the protected specimen brushings, 10 to the 4 and 10 to the power of 3 colony forming units are generally taken up respectively. Then this other criteria can be either of these samples, which is ET, bowel, brushings, or lung tissue. Along with that, gram staining, which is showing some of the polymorphic nucleus cells and the presence of more than 10 squamous cells. It is very important. This is criteria 2. And thirdly, अगर इन दोनों में से criteria 1 और criteria 2 में से कहीं से कुछ नहीं आ रहा, the second can be organism which can be prevalent in pleural fluid from the lung histopathology, or any diagnostic test which is positive in respiratory viruses or for the Legionella species. So that can also be considered as possible VAP. How do you look forward for the surveillance of VAP? So VAP rate, it is generally defined by the number of ventilator associated pneumonia cases per month, and the denominator includes the number of mechanical ventilator days per month into 1000. So this is how the surveillance of VAP is generally taken up. When we talk about the VAE tracking sheet, again, the same prerequisites for patient name, when the patient was admitted, or whether after 48 hours of intubation only patient developed. In all these cases, when we talk about catheter-associated UTI, when we talk about VAP, either we talk about central line-associated bloodstream infection, in some cases, may please ensure at the time of the admission, at the time of insertion in situ of any catheter or any endotracheal tube or any central line, please ensure the same screening for the screening purpose. Definitely, you need to send the primary samples to the lab as soon as possible. So during the time of screening, the primary samples are sterile, and after 48-hour samples, what we have received in the lab, they are positive for any microorganism, then only we label the patient as either of the healthcare associated infections. So date of admission, date of baseline culture, whether it was positive or negative. If baseline culture is positive, this does not include in healthcare associated infection. If it is beyond, after the baseline, after 48 hours, another sample and patient has worsened and has not responded, then it can be labeled HAI. So date of ventilation, time, what is the P value, FiO2 value, what about the counts, temperature, what are the different antibiotics given, name the isolate which was given, and when this antibiotic was given. After the isolation of the organism or previously before the isolation of the organism only, the antibiotic was given. Again, the same infection control department daily surveillance for the different. Now we talk about the ventilator for the whole days, how many patients were there, whether the other cleaning practices were adhered or not. So what is the treatment for? For late onset VAP, we have limited spectrum of antibiotics. Nowadays with MDR Klebsiella, we have this ceftazidime-avibactam combination. Nowadays we have developed resistance for that also. So very quickly we can talk about these all drugs have been enlisted in strict antibiotics and should not be given without prescription. Treatment of early onset VAP, second and third generation cephalosporins can be given, or a combination of fluoroquinolones or aminopenicillins and sulbactams. Lastly, we have the carbapenemases, we can be given. Treatment of late onset VAP, again, third generation cephalosporins, carbapenemases, aminoglycosides can be considered as the drug of choice. For anti-pseudomonal, we have ceftazidime and the fluoroquinolones. And coverage from MRSAs, we have vancomycin and lanoxidil. You have to be very, very precise when you're talking about vancomycin, when we talk about ceftazidime-avibactam, when we talk about carbapenemases, are we having the MIC values or is it by disdiffusion? If you're labeling a drug to be resistant, whether it was by disdiffusion or by MIC values. Vancomycin for carbapenemases, so for ceftazidime-avibactam, we definitely look for the MIC values or if there is any MIC creeping is there. So how do you prevent that? Anywhere when you talk about the road roller of infection control, nullifies everything, it flattens the curve of the healthcare associated infections only by the infection control practices. So hand hygiene is a prerequisite for infection control. Talking about the 5-element VAP bundle, these are the 5 main elements of VAP bundle. First is oral care with chlorhexidine. We need to have a good oral care thrush with a toothpaste and with chlorhexidine goggles. Then stress ulcers are very, very predominant in VAP patients because lying down position, they are more prone for gastric ulcers. So PPIs are very, very helpful for this stress ulcer prophylaxis. Then daily sedation assessment and spontaneous breathing trials. Earlier, when the patient is on intubation, definitely they are giving more of sedative so that the dilatation is there and definitely patient is much more in a comfortable position to relax. But daily sedation assessment eventually after 48 to 72 hours, it has to be checked down and the value has to be lowered down. And more of the breathing and the spontaneous exercise will really help the patient to eventually come out of this VAP. Then deep vein thrombosis, as I said, sedation assessment, spontaneous breathing trial, and also with the head and of the bed elevation with the help of the physiotherapy exercising, blowing exercises, they are very, very important for the patient of ventilator-associated pneumonias to come out with. As I said, daily oral care with chlorhexidine can help in inhibiting dental plaques and gingivitis. So this is the ventilator bundle checklist we have. So again, the name of the patient, oral care, how do you give out on a scale of 10, how do you give it? Daily sedation medication, आपने उसको value taper करी है कि नहीं करी है, that is important. TVT prophylaxis, whether the patient is able to move the limb, not sitting at one particular position, and subgluteal suction. When a patient is not lying down and regular exercises and regular breathing trials have been done with the patient. So this is an event form for ventilator associated event. Again, the same criteria, patient name, address, gender, date of the event, date of the procedure when patient was intubated, and when exactly we are localizing the patient to be as labeled as ventilator associated pneumonia. So how much was this FiO2 value, PEEP values, whether it is a possible VAR. So three criteria, criteria 1, criteria 2 and criteria 3. अगर तीनों के तीनों चारों samples में से how much was the colony forming unit, second criteria either of one was there, thirdly इन दोनों में से किसी का नहीं हो पाया तो fourth criteria में से either of these diagnostic parameters have been come forward or not. What was the organism which was labeled, for how long the antibiotics have been started. So this is VAE form. Patient, what were the chief complaints of the patient? What was the provisional diagnosis? Name of the organism, what was the colony forming unit? And what was the specimen also taken, whether it was a bowel sample, whether it is ET secretion or whether it is any bronchial washings. Again, the prerequisites, hand washing, standard precaution, hand washing has to be there. Very quickly, if at all, I can move to central line associated bloodstream infections, CLEP-C. So there are two words when we talk about CLEP-C. So two terminologies are, one is catheter related bloodstream infection, that is CRBSI, and the other one is central line associated bloodstream infection. So CRBSI is used clinically for the lab or the diagnostic or the treatment purpose, whereas CLEP-C, it is mainly used for surveillance purpose only. And when we talk about CLEP-C, how do you diagnose it? So number of central line bloodstream infection cases, denominator is total number of central line days multiplied by 1,000. So when do you call it as LCBI? So this is the first criterion, laboratory confirmed bloodstream infection. The name itself says that patient has been ideally, the central line has been placed. Patient has a recognized pathogen with one or more blood cultures are sent. It has to be identified that at the time of screening, bloodstream for the ruling of the bloodstream infections, please ensure 2 blood samples are generally sent. And at least one of the following signs and symptoms, fever, chills and rigor, and positive laboratory results, which are not related to the infection at the other site. So blood infection, the organism has to be there, one of the signs and symptoms has to be there, and either of the bottles has to come positive for laboratory confirmed bloodstream infections. So talking about what are the different risk factors, how we spoke about in catheter associated UTI, same is the case with catheters with multiple lumens. What are the device related, what are the patient related, and what are the healthcare related or the caregiver related challenges what we face, which becomes a risk factors for central line associated bloodstream infections. When you talk about patient related, of course, the age, the immune compromised status, any underlying diseases are there, or loss of skin integrity. Device related has to be catheter related only. The how the catheter is made, what is the flexibility, what is the type of catheter, how many lumens are there, more than the number of lumens, where the site of the catheter is there, because subclavian vein is the most preferred site followed by the jugular one. And in jugular vein, the catheter is more of the colonized site for the catheter central line associated bloodstream infection. Femoral vein has the highest risk of developing CLEP-Cs. And lastly, we have the healthcare worker-related infections that may be because of the poor hand hygiene or the lack of sterile practices, poor personal skin. Any untrained personnel is actually inserting the central line that can be hazardous to the patient. Talking about what are the most important etiological agents, Staphylococcus aureus, MRSA is a nightmare to any physician. Pseudomonas aeruginosa can actually have nightmares again because these gram-positive and gram-negative bacteria are very, very prone for central line associated bloodstream infections. Other parameters from the Pseudomonaceae family can be Burkholderia, Stenotrophomonas maltophilia, gram-negative bacteria like E. coli from the Enterobacteriaceae family. Many a times Candida albicans, Enterococcus, Serratia, Coagulase negative Staphylococcus. There are many times it is seen that cons is generally not reported, but we have to look for the clinical signs and symptoms. If it is there, if the signs and symptoms and 2 of the blood culture bottles, either of one is giving cons, so we really need to report as per the clinical correlation. As I've already said that because of the catheter related, it's a foreign body insertion, there can be a biofilm production. There is a colonization in the biofilm and leading to sepsis, thrombophlebitis, and leading to SIRS or the systemic infection in catheter-related bloodstream infection. So how do you diagnose the CRBSI? When we talk about surveillance parameter, first and the foremost thing, only paired blood cultures should be encouraged. There, no single bottle, no single peripheral line should be sent for. Paired 2 blood culture bottles has to be sent to the microbiology department to rule out CRBSI. No catheter tip should be encouraged for. When we talk about COTI also, when we talk about VAP also, ET secretion, ET tube or catheter tube, urinary catheter tube, same way, central line catheter tip. Catheter tip culture should not be encouraged at all. It should be contraindicated. One word about differential time to positivity. This is a very challenging part. Every now and then my ID specialist keeps on asking us, what is a DTP? What is a DTP? This is a very common question our microbiology department faces. So when you've collected a sample, in this picture, I think it is written very well, Bactec, this machine is. So what is the collection time? What time it has arrived to the lab? After arriving to the lab, when it has entered into the Bactec bottle, after the entry into the Bactec bottle, when it has signed positive. So time between, difference in time to positivity between the blood culture drawn simultaneously from the CBC or a peripheral line. Aapne kab blood collect kiya from the time it has signaled positive. That is the differential time to positivity. And sometimes DTP of more than 2 hours shows good sensitivity and specificity for the detection of clefts. So DTP, please adhere to that from the time it has been collected, from the time it has come positive. That is nothing but the differential time to positivity. Very challenging. Many a times I ask date mein, these questions are asked by to the microbiologist. So this is one central line bundle checklist. Again, the prerequisites are the same. When the catheter was inserted, who inserted it, who removed it on, what was the time of insertion, what were the prerequisites, whether hand hygiene was taken care, barrier precautions liye gaye the, antisepsis hua tha, dressing was done properly or not. So what is the time duration, how and when you're changing the dressing, that is also very important. So specify disinfection, whichever use, type of dressing which has been used, who has done it, and reason for the femoral site. Because as I said, subclavian vein is the most preferred one, followed by jugular vein. Lastly, अगर आप femoral site ले रहे हैं, क्यों लिया है आपने, उसका reasoning आपको देना चाहिए. So this is please close your mics. Central line procedural checklist. The same way the other checklists हमारे पास हैं. So procedural checklist, whether surgical wash was done, mark the excess site, safety practices was taken care, cap, mask, all the PPE were worn before it. Who did the precautions, hand washing and mask and gloves, everything was adhered. All the staff in the room wear a mask, was sterile technique maintained and applying dressing was maintained, infection control practices were taken care or not. If any comments related to that, infection control nurse can put it up. These are some of the practices from abroad, how people are generally putting up the central line catheters, CVC catheters. This is the central line maintenance checklist individually. When it was placed, date of insertion, eventually when it will be removed, ICU se discharge hua hai, ICU mein admission kab hua hai. So what are these on the scale of 10, you have to rank it. So what are the strategies for prevention of central catheter related or central line associated infections? Quality assurance and continuous education, how do you ensure it? So continuously teaching or training of your staff personnel, healthcare associated infections ke liye update karte rahe. Healthcare workers are emphasized more on hand hygiene, isolation practices, for barrier nursing, for standard precautions, whether it is being adhered or not. So quality assurance is the prime for the prevention of catheter related infections. As I said, that subclavian site is the most preferred one rather than the jugular and the femoral. Hand hygiene practices, whether the maximum barrier precautions were taken while insertion. Changing administration sets or at appropriate levels. Here, one point I would like to add, the frequency of change of dressings, it depends, like gauge pieces, every 2 days has to be changed, semi-permeable dressings, every 7 days has to be changed, and implanted catheters are the once in a week, it has to be checked up for changing or not. So remove catheters after it has been used. Chlorhexidine containing cutaneous antiseptics, I've just spoken about. Transparent semi-permeable polyurethane dressings. And please ensure every 7th day it is taken care of, it is changed on. So how do you fill up the event form? We have spoken about the surveillance. We have spoken about the checklist. Now this is the event form. Same like COTI and VAP. We have it, the prerequisites. What was the time of the procedure? Event time of clepsy. What is permanent central line hai? Kya temporary hai? Where was it inserted? Date of device insertion. What are the signs and symptoms? And laboratory confirmed bloodstream infection chahiye na hame. So whether the blood cultures, paired blood culture was positive or not, one or more blood culture is positive. Common commensal to nahi hai. Even if at all you are planning to give it as cons, please ensure whether the clinical picture speaks up the same way, because reporting a commensal will not help a clinician in your system. Right. And lastly, clepsy contributed to death or not, because it is fatal. It is definitely leading to bacteremia, septicemia. So it is fatal for the patient, whether the patient has lived or not. You have to document that also. And lastly, one word about the antimicrobial log profile access. We really need to ensure the antimicrobial adherence system, whether which all antibiotics has been given and whether it was tapered, and after the isolation of the organism, what antibiotics were given. Last but not the least, we have this surgical site infections. As we are running short of time, I quickly have to finish this up. SSIs, two types, incisional and organ space. And in incisional also, we have superficial and deep incisional SSIs. So when do we call it as superficial incisional? Infection which is occurring within 30 days after the surgery and involves only the skin on the subcutaneous tissue. With one of the following criteria has to be there, with or without laboratory confirmation, but pain or tenderness or localized swelling has to be there. So within 30 days, with either of the signs and symptoms, with or with laboratory confirmation, is defined as superficial incisional surgical site infection. So when do we not report SSIs? A stitch abscess? No, it is not a surgical site infection. Any episiotomy wound or a newborn circumcision sign, that is not a SSI. Infected burn wound is also not SSI. Many a times in NABH we face this. When people say that this is a SSI, we have filled up the form for SSI. No, burns infection is not a SSI. So next point is, what is deep incisional SSI? Infection which occurs within 30 to 90 days after the surgery and involves deep soft tissues like facial or the muscle layers of the incision. Culture has to be positive, and one of the positive points of either a discharge or the signs and symptoms, pain and tenderness at the site is there. It is considered as deep incisional SSI. And when do we call this as organ space? Again, the time duration between 30 to 90 days after the operation, involving parts of the body deeper than the muscle, maybe some organ spaces. Culture has to be positive. Again, signs and symptoms has to be positive. What are the risk factors? Again, immunocompromised status, any debilitating diseases, steroid use, any prolonged hospital stay, patient is malnourished, or any pre-op nasal colonization with staph aureus. Let me tell you, for any surgeon, staph aureus, MRSA is a nightmare. We have this, it's a very beautiful picture. Guide to hospital, we have the MRSA ward, MRSA clinic, MRSA specialist unit, department of MRSA, because once MRSA outbreak is there, you are in a deep soup that how we are going to treat it and how we are going to take care of the carriers. So MRSA is any day a nightmare for any physician or a surgeon. So what are the different organisms involved? There are surgical site infections, MRSA being the predominant one, Enterococcus, another gram-positive organism, and gram-negative bacteria like E. coli, Pseudomonas aeruginosa, Enterobacter, Proteus mirabilis, Klebsiella pneumoniae, and sometimes anaerobes like Bacteroides fragilis also in bowel abrasion and abdominal infections. We see it. This is a checklist for surgical site infections. Sorry, this is an event form. Again, the prerequisites, date of event, when was the procedure done, what are different location of in plan of the infection surveillance, areas where we have done specific event, what are the different signs and symptoms, and what was the organism involved in any of the blood specimen or the wound specimen, what we have followed out of. Right? This is a surveillance pointer. How do we label it as it was superficial, whether it was deep, what were the pointers, baseline culture, what was the antibiotic therapy, what was given, procedure which was carried out, and what are the clippers jo humne add kiye the. What are the inputs from the microbiology and the clinician side? Why did the patient develop surgical site infection? What were the corrective and preventive actions? So when we talk about standard and universal precautions, I have said it in throughout my presentation: hand hygiene, hand hygiene, hand hygiene. Use of personal protective equipment, especially when you are adhering and following any procedure, whether safe injection practices were being followed or not, and environmental medical equipment cleaning, whether the equipments while doing a surgery, whether they were clean or not, eventually, otherwise they would have led to surgical site infection. I think by now everybody might be knowing about hand hygiene. What are the 5 movements of hand hygiene? This picture is a very well-known, renowned picture. So when do we use 5 movements of hand hygiene? Before touching the patient, after contact with any body fluids or other body secretions, prior to performing before any aseptic performance, after touching the patient, and after touching the surrounding of the patient. These are the 5 crucial movements for hand hygiene. Very quickly, if I'll just open my video also, if all of us can just follow up, I haven't seen. If all of you can just pick up your cameras and we can have this 6 steps of hand hygiene. If I can see everybody on the camera screen, because last but not the least, definitely this point is very, very important for all of us. If all of you can please open your screens and we can just follow the 6 steps of hand hygiene. So first is opening and closing the tap is not the step of hand hygiene. It is not a step. Aapne tap on kiya, aapne tap close kiya, towel use kiya. No, they are not the steps of hand hygiene. So first is, I think I'm visible to everybody. I don't know. Maybe. Okay. First is rubbing your palm to palm. You've taken up the hand wash. You have taken up water. You're forming a lather. Palm to palm, first step. Second one is dorsum of one palm over the other one. Second step. On both the hands you have to do. Third one is interdigital, right? Fourth one, making the knuckles and you're cleaning it. Fifth one, thumbs up. Pay particular attention to the thumbs up. Why? Because this anatomical snuff box area is very, very important and many a times left out of not cleaning it off. And lastly, press the fingertips onto the palm of each hand. Right? So first, second, third, fourth one. ऐसे याद कर लीजिए. Fourth, fifth one, thumbs up. And sixth one. Right? So these were the 6 steps of hand washing. हाँ, और ये चीज हमें बहुत बड़ी सुनाई जाती है कमिंग टू इन्फेक्शन कंट्रोल प्रैक्टिसेस. हाथ धोना ही तो है, क्या बड़ी बात है जो आप हमें सिखाना चाह रहे हो. So please let me, in this era of technology, outfitting common sense, though common sense is not so common in common people, as we all know, as we all say. Hand washing ही तो है, हाथ धोना ही तो सिखा रहे हैं. How difficult it is, but yet people don't do it. So please ensure your healthcare workers, your healthcare staff to have strict standard basic precautions of hand washing, which will eradicate 50 to 60% of your healthcare associated infections via just one single hand washing 6 steps. Right? Thank you so very much for this 1 hour of patience of hearing me.